So today we're going to spend some time talking about the complex conversion knee replacement in a patient with a retained femoral nail after a femoral shaft fracture. And this is the type of situation where a patient has had a prior trauma, required intramedullary instrumentation, and then later develops post-traumatic knee arthritis. And the challenge in this situation is how to manage the arthritis in the presence of retained hardware. And we'll go through some of the considerations involved in that assessment. In this presentation, we have a patient who has already had one knee replaced on the opposite side. We are now focusing on this side. On this weight-bearing view, the joint space is completely gone. This is what we call bone on bone. In the femur, however, there is an intramedullary nail from a prior femoral shaft fracture. The fracture was stabilized with the nail and secured with two distal locking screws for rotation and length. The problem now is that this hardware can interfere both with the instrumentation necessary for a knee replacement and with the final components themselves. The challenge becomes how to work around this retained implant. Historically, this problem was managed in two stages. Stage one was the surgery under anesthesia to remove the nail from the top where it was originally inserted. Then stage two, the patient returned another day for the eventual knee replacement. Later, as we became more adept, we moved to one-stage procedures where the hip was prepped and draped, the nail removed, and then the knee prepped and draped and exposed, all under the same anesthetic. And the reason the nail had to be removed at that time is that conventional knee replacement or traditional knee replacement uses intramedullary alignment. So a pilot hole is drilled into the femur and a long rod is placed down the shaft of the canal to establish anatomic alignment. This alignment guides the angle of the distal cut and coronal and sagittal positioning. But if a femoral nail is present, the rod cannot pass. So historically, removal was always necessary. Rod removal was always technically challenging. There were so many different types of rods, at least a dozen, each with different insertion mechanisms and screw heads. And we often had to identify the manufacturer and obtain specialized tools to remove it safely. However, with the advent of robotic surgery, this changed. And instead of requiring intramedullary access, we obtained alignment from the CT scan. And the CT scan allowed us to locate the center of the femoral head and the ankle to establish anatomical alignment without having to access the canal. And this meant that the rod could remain in place, reducing morbidity and complexity. Once we know that the rod will not block our alignment, we must check whether it now will interfere with the implant itself, which we call hardware impingement. And this requires pre-planning. And then we start with a CT scan, and from that, we'll make a three-dimensional model of the knee itself. And on this screen, we can see the tibia on the bottom and the femur on the top. And we're going to look at it in all three planes. We'll look at it from the front, we'll look at it axially, and we'll look at it from the side. And as we can see, the tibial side is relatively straightforward. This is a standard deformity with no retained hardware. When we look at the femoral side, now we have very important information. We see the nail, but we see the nail is very proximal. It is out of the way of our implant. And so this is the superior or the highest portion of our implant. We can see that we're well away from the nail. So the nail will not block our implant. We can also see the distal screws are out of the zone of the implant. And this confirms that the hardware will not interfere with the implant placement, and we can now proceed in one stage without the need for hardware removal. The alignment is established. We evaluate soft tissue balance, and we start always in flexion. And in this example, it's a varus knee. There's bone on bone medially, so it's not surprising that we are tighter on the medial side than the lateral side. This gives us a trapezoidal flexion gap. We will now adjust our components by making this a little bit more varus and then this rotating externally so that we have a rectangular flexion gap. In extension, we can see that we've added a little bit of varus from the femur on the tibia, and we've added a little bit more varus, all staying within a neutral alignment, and now we've established also an extension, a rectangular extension gap. We've evaluated the anatomy, we've determined soft tissue balance, and made very precise adjustments based on the patient's degree of contracture and soft deformity. We then go to a final position check. And then here we see in the coronal alignment, we have 6 millimeters off the medial side, 3 off the lateral side. On the axial, we see our patellofemoral groove is congruent with the trochlea. We've maintained offset. And when we look at the sagittal image, we can see we have the proper anterior-posterior sizing, maintenance of offset with no possibility of notching. In the tibia, we have a neutral alignment. The keel is straight down the center, neutral rotation, and we have a 3-degree posterior slope. And then our outcome shows that the postoperative radiographs show exactly what was planned. So the nail and the locking screws remain in place. They remain very superior. They're outside the zone of the knee replacement itself. The tibial and femoral alignment are in neutral. The components are well mated. The femur is centered within the condyles and the tibia is perpendicular, and the lateral shows an appropriate slope, sizing, and offset with the nail safely out of the way. So this case illustrates how enabling technology has allowed us to move beyond 2-stage procedures to 1-stage procedures. And it also gives us the information to know ahead of time, rather than intraoperatively, that the nail will not be in the way and that we won't have to start digging around to remove it. Thank you very much.